Welcome everyone to our session this morning. It's entitled Transforming EP Workflow with Non-Invasive ECG Localization. I'm Dr. Tomasoni from Lexington, Kentucky, and our first presenter is Dr. Nair from St. Bernard's Medical Center, who will be discussing the improved AF trial. Basically, this is a trial sponsored by Vector, which is looking at randomized prospective evaluation in multi-centers and the effect of VMAP in ablation in atrial fibrillation management. The good news is enrollment right now is over halfway complete, and this is representing and reflecting the excellent momentum that's being achieved through the participating sites. And I think it's an important trial to sort of establish the basis of the level of evidence to see what VMAP might be doing for identifying non-pulmonary vein sources of atrial fibrillation in a generalized community setting. So Dr. Nair will discuss this on her presentation. Thank you.
Well, thank you so much. So what I decided to do is maybe start off with a little bit of overview on what Vector is. Not everybody's familiar with Vector, and if you are, just pardon me. But I thought we'll start off with talking a little bit about what EKG localization even means in the world of atrial fibrillation. These are my disclosures. I am an investigator in the improved AF trial. So the question is there a need, right? Is there a need for more mapping than the high density mapping that we're doing in the lab? And the question is, have we reached a ceiling on success with AF ablation, especially in those complex AF, persistent AF, redo patients, etc. And then the question is, who are the patients that we probably should do more than the PVs? Maybe who are the patients who, I don't know, does everybody need every PV isolated? I don't know. What do you do with patients who have persistent AF that now have a durably isolated pulmonary vein or pulmonary vein and posterior wall? Where do you go next? When do you go to the right atrium? So these are all questions that I think we kind of wonder. And I think to me that's where the role of mapping for AF comes in. Of course, there is a role in the ventricular space. I'm not going to focus a lot on that. And access to ventricular ablation in many labs is limited because of the concern operators have about what their success is going to be, etc. So I think there's a role for that as well that can be discussed later. But Vector Medical is an AI-based, non-invasive arrhythmia mapping company, and it's called the VMAP. Okay? And what VMAP does is it takes 12-lead EKG, it analyzes it from different cardiac arrhythmias, and using a mapping library of simulated clinical cases, it provides probabilistic locations of where the targets could be, and that guides your ablation therapy. So you're taking the patient's EKG, you're running it through the software, and it kind of gives you that model that you're seeing is not the patient's CT. It's just a model of the right atrium and the left atrium and the ventricle for that matter. And it kind of gives you what are called cold spots and hot spots, and you can potentially see where those triggers are coming from. And the idea is that you take this, so the way I look at it, the system is FDA cleared, it is non-invasive. So these are the things that kind of resonate with me because you don't have to worry about how gotta worry about how you get it into the lab, right? And it localizes arrhythmogenic substrate for both focal, macro reentrant, and fibrillatory arrhythmias. And of course, you can use it in all the chambers, right? All 4 chambers. It's not just meant for one chamber, which I think is extremely valuable. And the one thing that I would say is, the setup is super simple. All it is you have a central unit. It's almost like a laptop, and then you have this disposable kit, which is a USB. So it doesn't require a lot of footprint in the lab, which is a huge deal for most of us in our lab. And then, of course, as I said, you can use it. The beauty is you're looking at AF, and you're looking at AF on an EKG. So maybe the first time you see that is in your clinic. So you don't have to wait till you come to the lab to decide, do I need this? Where do I go? How complex is this procedure going to be? We have a zillion PFA tools now. Which tool set do I use? So you can do it in the clinic, you can do it in the lab, and then of course it doesn't add on a lot of time. It takes about 1 to 2 minutes at most, and usually it takes more time because I ask them to rerun it again because I want to see validity that it's doing the same thing. But usually it does it really well. And the biggest thing, it is reimbursable. There is a CPT code for it, so the hospital does get paid if you do use it in the clinic, not quite in the lab. Now, I will say I won't go a lot into the VMAP study. The VMAP study was the blinded, multi-center, independent, adjudicated study that looked at retrospective data on about 225 patients. And what they saw is that when they used VMAP, about 97% of the time, they were able to, the success rate was about, you were able to get accuracy in 97% of patients. And it was within 15 millimeters of, spatial accuracy. So you always wonder, when you get those hot spots, it's not related to the patient's CT. So I always say base of the appendage, what does that mean? So I look at the anterior base, and for me, that's like, okay, as long as it's within that radius, I'm okay. And the median mapping time in this was about 48 seconds. So I'll now go into, I'll skip on to the improved AF study, which I think is what I want to focus on. So the improved AF study is what I'm super excited about, and I got to be part of, or actually use the Vector Medical System and the VMAP as part of the study. It is artificial intelligence mapping for non-PV triggers for AF. And it is a persistent population, so it's prospective, multi-center, randomized controlled trial. So keyword is randomized. So we're randomizing in 24 sites across the US and Europe. Again, there is interim analysis and all that would be done. But we're looking at persistent patients. We're looking at redo AF patients, especially with persistent AF. And the idea is that you're going to ablate them with potentially PFA. But it's one-to-one randomization where the operator will do PVI as their lesion set, or they will randomize to PVI plus the VMAP triggers. And so the idea would be that we now have the opportunity to look at this and see what does VMAP do or give us, or what benefit does it have in this population. And of course, there's multiple primary and secondary endpoints. And what I want to show is, this is a recorded case. It's an edited version of a recorded case from the study, just to kind of show you what this is and how it works out. So this is a patient that's a 79-year-old male, persistent AF, previously failed cardioversion on amiodarone. So has had 2 cardioversions on multiple loading doses of amiodarone. Currently not on antiarrhythmics because we wanted the patient to come in. I mean, he said it was not working, so why am I taking it? And then currently was randomized to the treatment arm. So here you can see the presenting rhythm was AF. We're running the VMAP. As I said, it's pretty quick. And as you see this, the video will run through. What they will do is, you can see on the top middle screen there, they're collecting those P-wave areas, and that's what's getting used into the VMAP to tell me. So usually I tell them, do this while I'm getting access, I'm pre-closing. I have to do my PVI anyway. So I like to get it early on, and you can see they have their VMAP out there, and here you can see there's a hot spot in the mitral isthmus, and there's some cold spots in the posterior LA floor and anterior roof. And it's not, and that's why I call it hot and cold. Some are bright red. You'll see where that hot spot is. And so this is all happening while I'm getting my access. I'm getting my sheath. I'm doing my transeptal. I'm not sitting around waiting for this. This happens in the background. I'm going to do my PVI. That is, in this case, we're using the pentaspline catheter. No change in my workflow. You can see I've done a wide antral circumferential isolation. One thing we are very careful is doing that PVI and staying within the PVI, not extending it to the posterior wall in these cases. So we want to be real about the data when it comes out. So I think all the operators are very careful. I run the VMAP again post PVI because I want to see if it has changed since I did the PVI. So now you saw there was a hot spot in the anterior septum, and I'm like, you know what, I want to go after that. So we actually, it was along the base of the appendage, along the anterior wall. So we actually did the anterior septum, sorry, not the base of the appendage, anterior aspect of the right superior. And all I had to do was extend that antrum just a little bit. And once we did that, the patient converted into flutter, and I decided to do the posterior mitral isthmus, which was a hot spot before I started. So we went on to do the posterior mitral isthmus ablation. Of course, you can see I have access to Ferro Point, but I usually do a double lesion there. We know the durability of PFA and mitral isthmus is not the greatest. So what I did here is I actually stacked up the FARAWAVE and the FARAPOINT, because I mean the goal is, if you're going to do this, you got to have to get durable lesions. Of course, I got acute bidirectional block, but I'm trying to maximize my durability with the data we know with the mitral isthmus. So that's what you're seeing here. And you can obviously see, once we are done with this patient that had multiple attempts at cardioversion, now converted into sinus with ablating just those two hotspots. Very quickly, this is another patient, 81-year-old female, persistent AF, HFrEF, randomized to the treatment arm. You can see the VMAP, hotspot, low anterior LA septum. That's it. And a hotspot in the CTI. This is another thing. Most of the tools that we have for AF mapping, they're triggered to just left atrium, or you got to map the both sides. This one gives me, in that 1 second, 1 minute, I get to see the whole chain, both right and left. We're not forgetting the right atrium. And all I have is a hotspot in the CTI. So I'm obviously finishing my PVI. You can see very kind of, it's wide antral, but within the range of that antrum of the PV, not encroaching into that posterior wall. We're not debulking the atrium at all. And then after that, we are going to go ablate that low anterior septum. And because it was such a focal spot, we decided we are going to use the FARAPOINT catheter. And as I was actually getting the catheter and started the ablation, of course, the patient converted with that at that spot. We actually tried to do reinduction, and you can see as we were mapping in that area, I've bent the FARAPOINT catheter, and I'm getting to that low anterior septum, and the patient converts. And so we went on. I finished the CTI as well because that was a hot spot. We figured we might as well do it, and then try to reinduce, and we were not able to reinduce this patient. So in summary, I think to me, it allows for real-time decision making. You get to use your ablation tools. You get to prepare to how you come into the lab, what tools that you want to use, how you want to plan your day. All of this into one integrated workflow. And I'm really looking forward to seeing the results of improved AI. Thank you very much.
We're going to open up some questions for Dr. Anair. She has another talk coming up. Is there any questions from the audience? I have a question for you, Debbie. Can you explain to us, if you're seeing a few spots that are kind of floating and not close to where you might have done your set of pulmonary vein lesions, do you just go and ablate those sites, or do you try to anchor them, or do you try to do linear sets?
I try not to do linear sets, because I think it defeats the purpose for me. I mean, of course, if the hotspots are all kind of lined up and it looks like a line, then of course I make it a solid line. But if the hotspot is just a spot, and that's the thing, you don't get multiple. You get 1 or 2, maybe 3, maybe. And that's I don't want to do too much. I think, I've said this before, with the power that we have with PFA comes a lot of responsibility. We see all these ablation maps with so much ablation, so much destruction of the LA. I'd like to ablate less. And so that's what I try to do. That's why we pull out the focal catheter in many of these cases, so we could just target that. And to me, I think that is what's going to prove the validity of this system. And I want to see that. So now, if it is close to the antrum, of course I'll anchor it, because I don't want to leave a critical isthmus that is now going to be a target for a flutter.
Flutter, okay. All right, great. Thank you. Thanks so much. Our next presenter is Dr. Oza from Ascension, St. Vincent, Florida.
So I'll be discussing the Vital EP registry. It's essentially a VMAP-informed targeting of any arrhythmia, kind of in our usual workflow. It's a registry, it's registry data, so it's kind of real-world data on how this technology will be used. So it's an interesting kind of data set that we're going to get from that. Here are my disclosures. So I want to just go over, I know Devi explained kind of how this works, but how does it work in AFib? So they essentially simulate atrial activation to localize likely AFib sources by identifying patient-specific hotspots and evaluating AF sources across both atria. They compare it against 400,000 simulations, test different anatomies and ablation states, also highlights areas of conduction slowing and scar. to show curvature and reentry, both rotational and focal AFib sources. So it pairs that with potential substrate abnormalities that promote AFib. So it really tries to see endocardially from a surface mapping standpoint what's going on in the heart. So it's really an interesting model. So Vital EP was a multi-center registry, looked retrospectively at about 60 patients at 2 sites, and then prospectively at 50 patients across 3 sites. And the time frame of looking at these patients was procedure time to 30-day adverse event monitoring. And we just finished enrollment a few months ago, and we're going to look at data from the early AFib cohort. In AFib ablation, we looked at termination or AFib non-inducibility. In focal arrhythmias, we looked at procedure time, fluoroscopy time, and overall, we just wanted to see how this technology was going to be used. So I think it'll give us a good indication of that. So the Vital EP study, what it showed was in about 34 VMAP guided AFib ablations. It was the early multi-center experience of VMAP guided procedural, and it showed low procedure time, about 71 minutes. Mapping was very quick, less than 10 minutes. And it was a zero fluoro, they're all zero fluoro sites, so we really didn't use any fluoroscopy. And what that really shows is that we didn't have to deviate from our normal workflow. Everybody was able to use their normal techniques, their normal technology, and it was really agnostic to how you did your AFib ablation. You were able to continue that zero fluoro workflow. We had frequent AFib termination about 33% of the time. The vast majority of these cases, all but 5, were persistent or long-standing persistent. We were able to terminate these cases. About 44% were at least one previous ablation, if not more. So this was encouraging. Rates of non-inducibility after the procedure was about 60%. And I think overall, this was very, very encouraging. When we compare this to other mapping technologies, AFib mapping technologies, all of these other technologies require endocardial mapping. I think that's really where this shines, is that you really don't need to spend time mapping. You don't need any extra mapping catheters. You can really go to a very targeted area and spend your time there and go straight to the ablation, which really accounts for these very low procedure times. And again, I think the zero fluoro, I mean, obviously that really has to do with the sites, but what that shows us is that we can continue our normal workflows. This really fits into your regular everyday workflow. It doesn't really change the flow of your day at all. So I'm going to go over a case, and this is one of those cases you really hate to see. It was a persistent patient, lady in her 70s. She had a prior PVI with posterior wall. And what you really hate to see in these patients is that they come back with paroxysmal AFib. And that's what she had. She had symptomatic paroxysmal AFib, had lots of PACs, runs of irregular atrial tachycardia, as well as just runs of AFib lasting 1 to 2 hours. So very symptomatic. And these are very difficult cases to treat without advanced mapping such as this. So at the beginning of the case, before we even started, we make sure the 12 lead is hooked up. So we caught several morphologies of PACs, we caught runs of irregular atrial tachycardia, and we kind of let the system do its thing. What it showed us was there was the morphologies all localized to the superior mid-RA septum with blushing towards the left. And that kind of guided our strategy and lesion set. And the goal of this, obviously, is to identify and ablate these recurrent AFib ATAC drivers and get rid of these paroxysms of AFib. So we started with this map here showing kind of right-sided septum and left side. Because she'd had a previous AFib ablation, I wanted to really start by going to the left side and making sure our veins were isolated and the posterior wall was isolated, which it was. And there's no real other, there wasn't really any substrate. All the other tissue on the left side was healthy. So that would have been a very difficult case to figure out in a patient that was, we'd sedated her, intubated her, and the AFib often calms down in those situations. So this would have been a very difficult case. So we started with the area that blushed to the left along the septum. There's a little bit of substrate there, so we homogenized that substrate, but I didn't really think that was going to affect too much in terms of the ectopy, and it didn't really. And there wasn't anything that really stood out in terms of electrograms there. So on the right side, we saw what you see here. We went over to the right side and we put our Octaray there. And we saw a lot of fractionation and early potentials there. That was in this little run of atrial tachycardia that they had. So we focused on that, ablated that area. Sorry. But then we started seeing more atrial tachycardia coming from the crista terminalis, superior area, superior part of that, almost near the SVC. And we saw other atrial tachycardias and PACs coming lower down. And when we'd initially mapped the right atrium, I did a quick and dirty map. Didn't see much low voltage until I saw these maps, and I kind of went back and obviously it's correlating with some pretty interesting intracardiac electrocardiography. And I looked at that area, and you see some kind of a strip of low voltage there with a lot of fractionation. So my final lesion set, really I ended up making a cavo-cavo line, isolating the SVC and making a cavo-cavo line down the lateral right atrium. And this is an area I probably wouldn't have looked at much, at least not initially, if I was going for a redo ablation. It's not the typical areas that you think you're going to have recurrence of atrial fibrillation. And what we were seeing during the case is that you'd have these runs of atrial tachycardia, sometimes degenerate to AFib, and it was just incessant. Once I ablated that line and got rid of the VMAP identified areas and all the fractionation we saw in those areas, everything calmed down, and really just the patient went into sinus, was non-inducible after that. So what takeaways from this talk and cases, especially this case, the VMAP localized multifocal AFib in drivers were identified across both the RA and LA. They correlated with substrate. So from this epicardial, from this surface map, we're able to really see what's going on inside the heart to a pretty accurate degree, and see how it correlated with the low voltage that we might have not even otherwise picked up unless we made a very careful map of the right atrium on the lateral right atrial wall. And it guided our targeted ablation. It was a very efficient procedure. I think the procedure itself took about an hour. I think it would have taken a lot longer than that to find this. You see a lot of ectopy. If you really try to do this on your own without this, you get a lot of ectopy when you try to map these sorts of atrial tachycardias and multifocal flutters and these triggers. So it makes it very challenging. So if you can go right to the source and do a very efficient map of these areas, I think it really cuts down on the time of these cases.
Great.
Thank you.
Thank you. We'll wait to hold a question for the last presentation, but that was great, Dr. Rosa. And that's the last presentation is Dr. Wang. He's going to be from Rush University Medical Center.
And I had one comment actually. Sometimes when we ablate an area, there's very little change in cycle length when the tachycardia switches. Sometimes the CS activation is the same. I found it actually to be very helpful, especially when there's a small P wave, but to actually look at that information and, because it's not incorporated in the mapping system.
No.
Yeah.
Yeah.
And
you couldn't
just
see
move
any
on.
changes in activation, because in the right atrium you really don't see much. So
Yeah.
it's very difficult to tell the differences and map these different multifocal PACs coming from the right side.
Yeah, and your complications usually happen when you ablate too much, too thermal in one area, so it's helpful. So I'm going to talk about now, VT case. I really think this technology is very well suited for PVCs and VT ablation, because really the ECG is sort of the global activation of the heart. And, we teach our fellows certain patterns, right, where a location could be. But really, it depends on the shape of the heart, the position of it, all of this factors into what the EKG could look like. And often there's fusion of wavefronts. So, I think this technology, it's been very useful in the VT workflow, especially as we try to sort of lessen the procedure time, right? As we map, you can catalog and sort of these things, but we'll talk about a case. So, let's see. We'll start with, this is actually a colleague's case, a hemodynamically unstable VT in a patient. So this is a tough scenario, right? Often these patients are sick, and you're really just, if you talk about procedural planning, you're getting all of this information during a case. The case is going along, and then you have to think about, am I going for an acute endpoint or a long-term endpoint? But there's a lot of information, that you're trying to do. And so in this particular patient, there was a VT. It was around 330 milliseconds. It wasn't well tolerated. The patient was on multiple vasopressors. We kind of all know the scenario. Is it prudent to map a patient like this? What do you do in the scenario? Do you terminate it and pace map? If we think about, the way this product was designed, actually they actually built it from actually mapping data. And with that, they simulated and created ECGs. And so this was sort of the library that it calls upon. But it's based actually on actual geographic anatomic data, right? And so although it projects a certain way, I'm not sure if this was talked about earlier, but actually the size of the ventricle, the chamber dimensions actually also gets factored into the location of that. And this is, again, where we're lacking, right, when we have just a 12-lead ECG. So there was actually a paper published by Dr. Ho and the San Diego group. It was recently published in Europace and actually looked at clinical outcomes, using AI-assisted VT ablation. And it was 2 centers with 60 patients with actually long-term outcomes data. And so they looked specifically at this cohort of patients with a control group and an AI-assisted workflow group. And so looked at basically the feasibility, of using AI-guided quick mapping in combination with conventional methods of mapping and selection of targets. And they also looked at, clinical outcomes such as ICD recurrence, VT, really hard outcomes, right, in these patients. And so, the primary endpoint was freedom from VT for ICD therapy. Here's an example of a 12-lead. And sometimes when we map in a case, patients go into VT, we kind of want to map it, but we shouldn't. Or maybe we're beginning to map the ventricle, but we don't know where substrate is. I found very helpful is that, we terminate the VTs. We go to Cardiolab, we stamp that time date, and then, we analyze this later. But it gives us, information about, where potential exits are, which can be very useful, especially if there's complex, non-super dense, spread out scar in the ventricle. You can't ablate everything, especially in some of these patients with low EF, such as this population. And so, sorry, how do I go back? Let's see. So here's an example of it. And then here's actually the activation map. And so we saw sort of where this, potential exit or corridor, end of the corridor was, based on, what the software actually thought it was based on the 12-lead ECG, which is pretty amazing, right? It's geographic information that's correlated, best fit to the potential patient's anatomy. And so it marks it for you, right? And this is without having to pace map. And, something with pace mapping is, if you think about it, is yes, you can get a 98% match, but you often don't pacing from the endocardium. And there can be a very wide area that's 92% or a very wide area that's 95%, but very nonspecific. But again, this software is sort of putting it actually onto the chamber anatomy. So the study, it was feasible to do this in 93% of patients, and entrainment mapping was also performed. And actually what's very interesting is that the exit or the critical part of the tachycardia circuit was within 4 millimeters, less than half a centimeter. And think about how big an ablation lesion is. The atrium, it's 6 centimeters, but if you're staying on for a minute, it's like a 1 centimeter, wide lesion. So that's very good accuracy. And in this population, time is, not just money, but it's, potentially going to help the patient survive the case. And so, this technology is very useful. So this is, actually, the site correlates with acute termination, right? But how does it actually correlate to durability of outcomes, which is meaning like, are you actually ablating the critical elements of the circuit? And this is, the beautiful part of the study is the actual, long-term outcomes of it. So it seemed to make a clinical difference in this population. Is it because, the operator is, more astute during the procedure, or are they able to do more ablation, or is it because the procedure was faster and they do well? It's probably all of the above, to be honest. So here is, I guess it doesn't play. Again, this sort of shows a circuit, and that area of blushing there is where, are you able to play it? It's okay. It's okay. But you can see basically the isochronal colors there. But you see the area that VMAP based on the 12 lead, which is going to be near the exit site for VT in a large scar. It goes through that corridor, right, with centrifugal activation. Now, actually, some patients have microentry, and so this map may not matter, but it's going to identify within less than half a centimeter the successful ablation site. And you can do all this data and analyze it retrospectively, right? Because you're just time stamping the ECG, you're going back and you can review it. So I personally found it to be very helpful for VT cases. Here's another case, this patient who had a CABG, prior CTO, ischemic cardiomyopathy. This is the voltage map. Again, very ugly, lots of scar. We've seen this before. VMAP, looking at the 12 lead ECG. And you can be very surprising. You can say like this transition, it's generally here. But the software actually, again, it correlates anatomically with prior maps of VT ablation cases, and it tends to, geographically fit well. And here's the circuit. And again, it correlates very well. And in this case, it would be near the exit of the site in a very large scar. So again, from a personal workflow, I think it's helped me do a lot of cases, especially as an operator. Not everyone has a group of fellows or multiple people there. You need the information when you see these tachycardias. They help you localize, what part of a scar in a patient that has too much scar, where to ablate. In a hemodynamically unstable patient, less time with low blood pressure, for sure leads to better outcomes. And that's it. Thank you.
Great, thank you. If you have any questions, please submit it to us. I have a couple of questions. So can you guys both comment on how important it is to remap after doing these things, and what's the utility of it and feasibility, and as far as efficiency of the workflow?
Well, I think remapping is critical. One, I think you want to see that this technology works, right? So if you ablate something, you want to make sure it goes away and it does so reproducibly. And I think that's one of the things that was really I think heartening to me about this technology, because you see this in AFib, that how can, off this little squiggly line between QRSs, can you get these beautiful maps and show you exactly where to go? So it's hard to kind of integrate that into your brain. But when you ablate a spot, even if it doesn't have effect on the AFib, and you remap it, it goes away. So it actually is seeing what's going on inside the heart from the surface map. So I think it's critical just from validating it to yourself, but also obviously you need to make sure you've ablated the right area, because you're correlating a model to an actual map that you're making. So you're always not exactly sure you got the right area, and it might be a little bit over from that. So you have to make sure you incorporate that into your lesion set. So I think remapping is great. I generally start mapping something else while they're running the remap. It takes a few minutes, so I'll maybe start mapping the right atrium while they're running the remap on the left. So it really doesn't affect my workflow at all. I'm able to really kind of incorporate it and not increase the time of the procedure.
Yeah, I agree completely with you. We're starting improved AF, so we'll be in that study. But I think it's analyzing a lot of ECGs, and it's looking for repetition. So if it finds a hot spot, I think probably it's a driver. We actually had a VFib case that we did, Purkinje networking. There was a scar, and there was a repetitive pattern actually, and it wasn't actually, it was locating somewhere very different actually where we ablated. So we did network the Purkinjes, paced, and the patient still kept going into VF just outside the scar, which is actually where VMAP said there was repetitive activity. And so we ablated there and identified it. But definitely it's a tool, it's adjunctive. It helps your brain focus kind of on, this is the area that, I need to work on. Mm-hmm. So
I think the other thing I forgot to mention is that you can ablate one focus and it'll uncover another focus. In that case I presented, it was initially on the high septum on the right side. Once we eliminated that, only then did the foci on the lateral wall really become apparent. So I think you can get rid of one driver, another one might uncover. So I think it's definitely important to remap.
Yeah, and I think that's probably the more critical part of remapping, I agree.
Yeah.
You find these other sources that probably wouldn't have been there, and if you didn't look for them, they're still there. Tell me about for VT, unstable VT. So our old workforce would be to bring them in, ischemics, map the entire scar, ablate the entire scar, try to reinduce, then try to pace map because they're unstable to kind of go after. How has it changed now with VMAP?
Yeah, there's been a paradigm shift in general. Like a patient, like in this study that's very sick, you can't ablate too much, but it's sort of like a non-stained AT that's very induced. We really are intentionally making these VT episodes very short, and it's, it could be microentrant, so it could all be there. Sometimes we map, it's very small, but often it's an exit, so it tells us what, I guess, to focus on. But it's a lot of information that you're sort of cataloging, which is the nice part of it. And you can actually pace map and see where it actually exits on VMAP, which is better than a percentage, because again, that percentage can be a wide area. So it's, if you really incorporate in your workflow, it can make a difference.
I had a question for you.
Yeah.
So in the data, it was pretty remarkable. It was 40 versus 80% success rates. It also looked at how often you could entrain. And in the control arm, they entrained about 40% of the time. Do you think a lot of this has to do with, unless you're able to entrain, you're not actually getting the exit? So just by because many times on these unstable VTs, we put them into VT, terminate it, and you have a template, and you start pace mapping everywhere to find a match. And like you said, it's a wide area. Do you think that entrainment is necessary to actually get those high, get success? Because that seems like the only difference. Either you have VMAP to get you to 80, or maybe you can only entrain 40% of these cases, and those are the ones that succeed more. I don't know, because we've always thought the failure was due to lack of proper tools, right? We always thought we weren't getting deep enough, and we weren't. But this shows that it might be the actual places we're burning that matter.
Yeah, no, it definitely could. For termination, and the data doesn't really say that just acute termination itself correlates to long term. Yeah, but I think what's tricky is if you're ablating on the outside, it may not be perfect entrainment. So you kind of have to figure out where the circuit is.
Yeah.
So I don't know if I really answered your question, but I don't know.
Our goal
Good question.
I think our goal would never do concealed entrainment or any entrainment pacing at this point. Trying to facilitate these long cases and dealing with scars. So anything that would guide where you can actually do a limited ablation, I think is really very helpful in that population. Our experience has also been, which is unique only when we start using vector, for VT ablations, we've found a lot of septal presentations where we burn on both the left ventricle and right ventricle to be successful. Whereas I probably wouldn't have done that previously, showing again after you burn one side on the LV that you might have a new site with a remap on the RV. Is that the experience that you guys have also had as well?
Yeah.
Agree. We had a perihizian case actually that, it was two places near the right-sided his, it moved, and then VMAP said it was left-sided. And then we were kind of like, maybe the patient will be okay. It's a little better, but then we went left-sided. That was a very recent. Why are you laughing? It was.
Was there a good rep at that case, or was there
yeah,
your typical rep? What was the story with that situation?
What's that? Oh no, she was there.
Well, yes, she
it's all
probably
near
was
the
eating
conduction
popcorn
system.
too.
Yeah.
I'm sure.
The patient did very well. Finally, because we went left-sided, it was definitive. Like the PVC went away.
Yeah.
But I think we were blading exits.
And I think it's, especially because it's near the conduction system, you want all the evidence you can get to make sure you're burning in the right area, because if you're going to get heart block, you want to make sure you got the VT.
Yeah, we didn't have arterial access or anything. It was kind of already long, and we were like, okay, we'll do it. So it made a difference. Yeah.
That's great. What about long-standing persistent AFib? Are you more likely to go after these patients now with the use of VMAP, or it make no change in your decision plan?
I think this will help risk stratify, hopefully, in the future. Maybe there's going to be a scenario where if you see certain patterns of VMAPs, they're not going to do well no matter what you do. And I think that sort of thing is going to be really interesting. I think definitely it gives me more I'm a little bit more aggressive with it because I kind of know the areas. I'm not just going to do a PVI posterior wall on all these people anymore. You're going to actually do a more nuanced ablation and go after other triggers. So I think obviously we still need more evidence, and improved is going to go a long way to helping us with that. But I think this potentially could make those patients a much more, I think, a better target for ablation.
All right. Any other questions from the audience? All right, sounds good. Well, thank you so much for coming to the session. Thank you, everyone.